changes.
And Ravneet's joined us. Hi, Ravneet. We were just sharing that we've got a packed agenda, so we're going to have to keep moving on the schedule.
Mine's quite concise as well.
Perfect. No, thank you for joining us. And I think Imrana's booked in, and Imrana's always got clear messaging, so I think that one will be good. I gather you had a good meeting yesterday, Wax.
Yeah. Lots of good meetings. Lots to talk about. With with everything going from CCGs to ICB, and the kind of focus shifting to system rather than primary care. There's some conversations we need to get into because we absolutely desperately need to find some efficiencies. Because that's going to be super important going forward, because we can't transform or do what we want to do or need to do actually just in the core kind of situation. So because of the financial position the way it is, we need to just think much more smartly and call in assets, I think.
But it seems to me, and we haven't had the sort of detailed conversation yet, we're going to have some really important conversations at the hospital, aren't we?
Yes,
there's an awful lot of activity that could change and be more, but not just more cost effective, just much more sensible for the patients.
No, it's all if we need to do this around patients, and we talked a bit about neighbourhoods as well, and so I spent a lot of time thinking about this, and the issue that we have in Newham is just the sheer size of the population. It's not really, it's in a small pocket. It's not really a neighbourhood, is it? It's you're literally everyone's your neighbour. Everyone is your neighbour.
It's bigger, isn't it, with the population growth and stuff. Yeah.
So that kind of, we have to think of Newhamifying that definition.
Anyway, colleagues are coming in, so I know our partner's chairing, but good morning, everyone, or good afternoon, everyone. Hi, Subir. We were just saying that Subir, your and Wax's items are going to need to be on time because we've got a packed agenda.
Definitely. Good.
I think we can wait a few minutes and then we will start.
Yeah. Hi, Shimmy. Nice to see you. Hi. You're clearly on the deck of that cruise still.
I wish.
Enviously looking at that lovely sunset in the background.
I hope it makes you all feel cool.
Need to create a little wind tunnel. Afternoon, Will. Good to see you.
How you doing?
Yeah.
You can see who's been on holiday and who needs one. It's like either everybody looks very chilled out and relaxed.
Or alternatively, those that have been on holiday and then come back and it's like, when did that happen? What was that holiday? I don't remember it.
It's a seasonal effect because weather is a little bit better now. So we're having a false seasonal effect.
I mean, you can tell that Rima's been on about 3 consecutive holidays.
I actually haven't at all, thank you.
You just look relaxed, Rima, and kind of in that holiday glow. That's what it is. That's what you mean.
Okay, I'm a bit tanned. That's just from here.
So I must admit, I'm keenly looking forward to my break. Not happened yet, but it will.
So Karen, I like that radio behind it.
Yeah, it's my my husband's mum's. It was. Yeah. Okay. In fact, I think it was her mum's. I think it was his grandmother's. Okay. So, and it does work.
Oh, good.
I know. It's a really old one.
Yeah.
I have. As you can see, set there before.
Yeah, I moved it to put various things, but yeah, there's so much clutter in my office. It's like it's the one room in the house.
It's like watching the Antiques Roadshow.
Yeah.
We all stop laughing cheekily.
No, so I was just about to say, am I very late? Because it looks like the meeting's been recorded for 27 minutes already. So we might want to switch off the recording and then switch it on when we start the actual meeting proper. Sorry.
Good plan. Good plan. Yeah, thank you. You got 23 of us now, our partner, so I don't know if you did want to.
That's fine. I think let's start. So good afternoon, everybody. For those of you that don't know me, I'm Dr. Rima Patel. I'm a GP at Dr. C. Patel Surgery and Vice Chair to Dr. Farouk at the Federation. I hope you've all been keeping well. I hope those of you who've managed to get away have had a good break. And I'm hoping that we're all ready for our winter season, although looking outside, what's going on. We've got a fully packed agenda, so I would appreciate if everybody could keep questions to the chat bar or raise your hand, and if there is an opportunity for you to ask, we will take advantage of that. And if the speakers could keep to time, that would be great. The meeting is being recorded, and if you've got any other comments that you wish to share, do please put them into the chat bar, and if you could mute if you're not speaking. So over to Karen, who's just going to give us a bit of an update.
Afternoon, everyone. It's really just two quick notices on behalf of Newham Health Collaborative and the Federation. So you'll have seen some communications from me around the election that we've had this summer over our board appointments. We went out to all the membership and invited them to make nominations and then potentially a process of election. In practice, we only had 3 nominations for the 3 positions that were up for election. And so the NHC election subcommittee, which didn't involve anyone who was involved in the election, was content to confirm that Nadine Farouk, Claire Davison and Dr. Rima Vaid have been elected as the practice director nominations for the board. We are in the process of selecting the clinical director nominations, and that process we'll be able to announce the outcome of at the next GP forum. And then the other one, that's all right, thanks Maggie, move on. The other one, just to give you advance notice that October the 19th, and we will remind you a bit nearer the time, we'll be having the annual general meeting for NHC, and as in previous AGMs, we'll set out what's been achieved over the year and what's been delivered on your behalf. And then also we will put forward some ideas about how the Federation should develop going forward. We'd really welcome people joining us because it helps us to make sure that we're reflecting the needs you want and making sure that the Federation reflects how our stakeholders and members are keen to see us develop. The venue, we're just finalising, probably Stratford Town Hall, but we will drop you an email notification. But if you could earmark Thursday the 19th of October in your diaries. And that's it from me. Thank you, Arpana.
Thanks, Karen. Subir and Dr. Waqqas. I think Waqqas is on the phone. So Subir, are you ready to go?
That's fine. So do you have the slides on the system so I just wanted to, Waqqas, do you want to start with winter preparedness?
So I'm going to pick up the flu and COVID. So if you had anything else that you wanted to kick off with, happy for you to kick off, or I can start as well because I've got my stuff up on screen as well. So
okay,
up to you.
Go ahead. Then I will come back. Yeah.
Okay, Mary, can we have the flu COVID slide, please? Should be the next one. Yeah. Okay. Good. So we were at PLT, myself and Subir, on Wednesday, and that will be recorded as well. And we went in to depth about two big changes. One that was a more acute change, and one that is something that's going to affect us going into the future. The first one was around the flu COVID, and I'll pick that up with you now. The second one was more about CQC, and we've had clear guidance around the timelines and when CQC will be inviting all providers to come forward to register for the new provider portal. I recommend you watch those series of webinars that can be found up on the Training Hub website, and we can share the links again as well, because you will start to receive calls from CQC about registering to the new portal for the new assessment framework from November onwards. Okay, so can we go back to that COVID and flu slide, please, Mary? Brilliant, excellent. This is what I was going to focus on, because we haven't got a fantastic amount of time, and everything else is recorded. So, as you know, big change came last week. Millions of people eligible now for COVID and flu vaccine. That's from the 11th of September. Wow, that's Monday. That's pretty early. And I know some of you have already started fantastic work around flu. I just went to Subir's practice to collect some flu vaccines to do some co-administration from Monday. Yeah, so in line with the expert guidance from the Department of Health and Social Care and Waqqas, so the UK Health Security Agency, everything's been brought forward because of the concern around the new variants. There's around 4 new variants that they've picked up from different countries, and because we've seen an increase in cases, and because stuff is traveling borders and stuff, this is now, they haven't called it sort of concern, but they've noticed this, and that's why they've actually brought the program forward. And it's actually been brought forward 4 weeks, and so that's a pretty significant leap, not only for us in terms of planning, but also for patients as well. So from Monday, which is the 11th, you can see the cohorts there. Residents in care homes for older adults. So we have a list in Newham. Most of our care homes, nursing homes, residential homes find themselves on that list. I've actually identified a couple today that aren't on there, and we'll speak to Lilia in the NHS NEL vaccinating team about that to try and reconcile some of that. But so we have a list of all those, and so ourselves, NHC roving team and Essex Lodge, working with some of the practices, will go out and start vaccinating those individuals with the COVID vaccination and the flu vaccination from Monday. So please do work with providers who are contacting you about lists of patients, etc., because we know names change from phase to phase to phase, and work with them to identify your patients who require that intervention in the care homes, etc. That has to be done within a short time frame. They expect us all to have done all of the care homes within a few weeks, and also, of course, that offer extends to staff. The next bullet there is all adults aged 65 years and over, and anybody turning 65 by the end of March 2024 is also eligible in that 65 years and over category. I'm hoping the searches have been done. I have been onto KEG, and my understanding is the searches are compliant with that, but please do bear that in mind. So if you get somebody who's coming through as a 64, is going to be 65 in March 2024, make sure you include them in that all-in category. Okay, persons aged 6 months to 64 is in a clinical risk group. So you know what NHS England have done, working with JCVI, is align the two programs. And actually, this is the closest the flu and the COVID have ever been. And so primary care will continue to vaccinate 2 to 3 year olds, the children, and everybody else will be vaccinated in school. And then everybody who's 16 plus will tend to come to our practices for their jabs, or pharmacies, or our vaccination hubs, as they were. So yeah, so do bear that in mind. Though it says here 6 months 64, the searches that you will have the 2 to 3 year olds and not that full complement up to 16. That doesn't stop us vaccinating anybody from 6 months to 64. Bear that in mind, but obviously the item of service will not reflect that. Frontline health and social care workers. This is a big change. So you know that none of us have been jabbed now for probably over a year. It's really important that we all get protected. Now on the WhatsApp, there was some querying around when this will be available and stuff. My understanding is that all 3 sites, Essex Lodge, Wood Grange, and NHC SLG Liberty Bridge will receive their COVID vaccinations on Monday. So we'll let you know the clinic times. Please do come forward if you're a carer, if you're a health and social care worker, do get your jab, and do the flu and the COVID together. And a little tip, maybe it might be worth coming along on a Friday. If you get a little bit of a flu when you have the jab normally, or a little bit of fever or a bit of an achy arm, it's probably better to come on the Friday when you're off on the Saturday and Sunday, and then back to work on Monday. I'm sending out a positive message, guys. So yeah, I don't want lots of people off with achy arms and stuff like that. And there's that bullet, and then the person's age 12 to 64 years who are household contacts. So I think that probably, so we've done a search at our practice and it's identified probably 30% of the population are eligible for flu and COVID. That's a big number. And actually the others who weren't eligible, and if you're 12 and above, probably are eligible because you're a contact and a carer. So it's really important that our carers registers are up to date, and then you communicate out to carers as well. But remember, this offer for flu and COVID extends to those individuals as well. We need to get as many people in as possible. The thing that's not on here, and I can't see it on there, is pregnant women. Pregnant women is a big cohort that we are supporting this time round. That's quite naughty. That should be there as a bullet. I took this directly, as you can see, from NHS England. But please do run a search for pregnant women and make sure that they get vaccinated as well. Okay, in terms of supporting the programme, you would have heard last week from the COVID vaccine, the item of service for the flu stays the same. For the COVID vaccination, there's an enhancement for a few weeks of, I think it's £5 for those who are vaccinated at the sites. And for care homes and housebound, it's £10 on top. Sorry, I think it's £5, sorry, on top of the, and that the housebound incentive has been extended to the care homes as well. So quite a lot of work for not fantastic incentive, but absolutely in the long run for patients and levels of flu and COVID, etc. It's super important that we get together and work together to efficiently immunize, vaccinate as many people as possible. Now, some people are going to ask about the new variants and stuff. Yes, there are new variants. We are using the vaccine that we used for the 12 plus in springtime, but we're expecting probably an updated vaccine later in the program from the COVID perspective, not the flu. But we've heard that before. Sometimes that gets delayed and stuff like that. Should not stop anybody coming forward. We know that the vaccine that was used at springtime will almost be as effective as any new vaccine that's created to cover off any new strains. I wouldn't want to hold the program up waiting for a new vaccine. Another little change that I wanted to communicate to you is about the 6 months to 4 years. We've been working on the 6 months to 4 years since sort of second week in June. The Newham uptake my understanding is around 15-16%, which is actually very, very good. Actually, Newham has, and some of your practices have the best uptake in the whole of the country. So in fact, North East London has done more 6 to 4 months than anybody else put together. So that's really, really good with protecting those children. NHS England yesterday, day before, changed their minds. They now want a 12-week gap rather than an 8-week gap. So that's important to communicate. And we're communicating out to those that have had a first dose in that 6 months to 4 years category. Some of those kids have had their second dose because we've been super efficient in Newham. And unfortunately, they're going to have a third dose, but that's not a problem. I've spoken to all of those that includes, and I'm sure Cara will be speaking to those that includes from the SLG perspective, and they'll be coming for a third dose when the new vaccine is out. For 5 to 11s, remember I've been talking about 12 plus 6 months to 4 years. For 5 to 11s, this is a real soup now, isn't it? Spaghetti soup. For 5 to 11s, we haven't got the new vaccine. It will be the Orange Stop Comirnaty at the moment. That hasn't gone out. We expect there to be a new vaccine, but we'll keep everybody posted. At this moment in time, there isn't an evergreen offer. So if anybody hasn't come for the first and second, there isn't an evergreen offer to support them. I don't think that's cool. We've kicked up a stink in Newham, and Lulia and the team have gone back to National and said, look, for a borough that has a population that comes in and out of the borough from other countries, from where they've had programs of COVID vaccination and not had a COVID vaccination, absolutely, we need to protect these individuals. So we think that we should be entitled for an evergreen offer. Let's see, and we'll keep you posted for that. That's all I wanted to say on the flu and the COVID. There is a lot there. I think the important things, 11th of September and those cohorts, and then remember pregnant women is really, really important. We'll crack on with the 6 months to 4 years. We don't need to bother you about that. We'll do all of the contacting around that. The 5 to 11s will keep you updated from the COVID perspective, and the 12 plus at risk, and then 65 plus all in are the ones that we need to think about. The other thing with the flu, remember the 2 to 3 year olds, really important that we get those numbers vaccinated up. And generally all the flu cohorts, as outlined there, we need to get vaccinated as well. Subir, that's all I wanted to say. Happy to take any questions and conscious of time.
Thank you, Wax. I think there's been a few comments and questions, but in the chat bar, but they've been looked at or answered.
Oh, wow, fantastic. Do you want me to scan through them?
Yeah, you can do.
Yeah, so so I think there's quite a few people. Do watch the PLT, that'll be great. Frontline staff, health and social care staff, carers, please come forward from Monday. Come down to the practice. We'll do late nights. We're doing 7 days a week. Essex Lodge will put their times on as well, as will SLG. We'll communicate those times to you. Please do come forward. And if you're not happy with just having the old vaccine, come forward within 10, 11, 12 weeks and we'll give you the new one if it ever materializes as well. So that's really important. And you know, it might be worth us putting together some comms that people can put up on their patient screens, Karen, and windows to say that if you're a carer, you too are eligible as well, because I've looked at some of the communication. I don't think it's fantastic, and I don't think it's complete. And we know that in a borough that has big numbers of clinically vulnerable, you also have a number of carers and contacts as well. So we want to make sure that they're all protected as well. The stuff around the CEG searches, for the flu searches, they're available. The problem is those flu searches don't align with the COVID. You would have seen the bulletin out from CEG yesterday. They're still working on the COVID searches. I'm really sorry about that. As NHS England brought the programme forward, that causes practical issues for everybody else involved in the program. Those CEG refresh searches will not be available for at least a couple of weeks from the COVID perspective, but do text out your patients with the flu messages if you've got your flu, and get them to self-book and get in for the vaccination. In terms of pharmacies offering COVID IMS for health and social care staff, if that's easy for you, by all means.
I think Will's replied back to that.
Okay, brilliant.
Further
Excellent.
down. I think one point can you pick up? So Tammy's talking about in the NHS app, the patient's status. So if they've had their flu vaccine and the COVID vaccination status is not up to date. So who is it that we can escalate that to?
Okay, so at this moment in time, if any of you have ever used Farmer Outcomes Pinnacle, NHS England are doing a big cleanup of all of their information. Before, we used to see when people have had flu and had their COVID vaccination. NHS England are updating all of that, and they will be updating the app as well. Tammy, does that cover off your question, or are you asking something even more specific?
No, it's just that we had a load of work last year about not double jabbing people, but also knowing where they are in the system. And if we really want NHS IT and tech to help us, then we need to have that information ASAP in the app. So we need to put the pressure on so that they get us that, so that it makes it all easier for us to, you know, chase the appropriate patient, because there were some things where patients were getting 4 and 5 text messages from different systems because no one was communicating with one another. I'm just, you know, aware that we don't want people to go, oh, I can't be asked anymore, which is what was happening, you know, sort of towards the tail end. So from a patient perspective,
it's quite interesting. So NHS England are not going to run their comms, and that's quite clear, until the 18th, Tammy. So letters won't be posted until the weekend before that. Are they going to go to the over 65 population? Well, they didn't last year, and they didn't the year before. So in terms of the app, I'll have a look at the app and see if any invites are being sent through, but I'm quite sure that the app does send through automatic invites and stuff like that. In terms of updating your immunisation page, whatever we see on our EMIS should be available to patients via the NHS app if we've given the access that they've asked for. I think that's on us to work with patients as well. In terms of for the vaccinators, that is a bit of an issue at the moment, because we're going live from Monday and we have no vaccination history in the box. Okay, so we can't see flu or previous COVID or anything like that. So we are actually going blind, and hoping with bated breath that NHS England can do something about that by Monday. And also, I think you all received the CEG bulletin yesterday with a link to the dashboard. If you click on that link, that dashboard, I've just spoken to the dashboard team, won't be ready for flu and COVID cohorts until 2 weeks' time as well. So bringing forward a program, like I said at the start of when we were talking, is really, really important for patients, but practically can cause lots of issues. I think we need to be absolutely patient and make sure this stuff is happening. But I'm trusting the teams and vaccinators have got stuff in place to mitigate against the risks that come with going blind and vaccinating like that, especially to care home residents who will have a clear history on the EMIS systems. So we're going in for care homes on Monday afternoon and Tuesday, and we've asked for just some information back from colleagues and access to the EMIS so we can make sure that we don't double jab as well. So lots in there, Tammy, but unfortunately, I don't think it's going to be crystal clear or perfect until the 18th. So if you are a vaccinator, do be warned, be really, really, really careful about double jabbing.
Okay, thank you, Wax. I'm just a bit mindful of the time. I can see Dr. Nabila Din's got her hand up. Nabila, can you be very quick? Sorry.
Yeah, it was a very quick suggestion. So for the sites that are vaccinating, I think it's really important to hand out those cards, because then if you've got someone with dementia or that won't remember that they've had it, if you've got that card with them, especially in the first 2 weeks, it's unlikely that they will get double jabbed with the flu vaccine if you've got that that time period before it goes live. So if you see what I mean, if you're giving them the card and then someone sort of says, oh, have you been vaccinated, and they pull out the card, there is less chance of you double vaccinating them.
Great. Thanks, Nabila. Subir, over to you. Sorry, you've got a little bit less time.
With the slide on, I'll just be very quickly. So welcome everyone. So when I started this morning, the 7:45, I opened my computer. First document I received, a red document. That means somebody has died. So this is a 56-year-old woman from Africa. She died of COVID. This is my first death. So only things I wanted to remind, not to scare people. It hasn't gone yet. It's still here. It's just hidden. It will come back again. So with this kind of weather, don't get very overexcited. Winter will come and it will hit us. So can I see my slide? So I can just talk about how to prepare ourselves for the winter. No, so there's the 4 area I'm going to talk. Is there any slide anybody showing? Maggie?
Okay, let me see if I can get it.
It should be coming. I can do it.
Yeah.
If you can't.
Okay. So the 4 area, 4 to 5 area, I'm going to quickly give people reminder. First thing, we have to go for our winter preparedness, and the winter preparedness means vaccination, immunizations, staff, infection control, health and safety, all these things you needed to run a general practice smooth, and it can meet up the demand it's coming on. So first thing I will tell everybody, check your defibrillator. It is working, because remember, we might be double jabbing people as well. So make sure that everything on the place, the batteries, everything. I had a disaster a few days ago. We have to quickly replace the defibrillator. It's a common thing, because the research doesn't happen every day in general practice. So that's why it sometimes goes out of the site. So be careful. Just have a look on the batteries working and everything on place. Things are fine, but when the things gone, everything gone wrong. Staff vaccination is very important. So the booster offered to every staff you can manage. If they are declined, you have to have those kind of documentation there. At the same time, make sure the PPE. I think we should offer a patient PPE if the patient is really unwell and you suspect the patient have some kind of viral infection. So keep some PPE or some kind of mask on the reception, so you can give it to. I don't know whether the big pool can come from, whether we can buy another bug. It depends how the things goes. If next 6 weeks time things going to escalate, at the moment it's 1 in 7. When it's become 1 in 5, hospital admission goes up. So that is the time we need to be more proactive. So be ready for everything. I don't want everybody to panic, but don't ignore these things. It will come back. So next things I'm going to go, prepare your business and continue to plan. Staff. How many staff is unwell, C-trap, is there any other budding system you have to do at the neighboring practice if 3 or 4 staff get unwell? So those kind of things, what we did before, just revise those things. So also revise your business continuity plan, which must include infection control, preparation of an isolation room, also all the safeguarding training for the staff who are going to vaccinate or face the patient. The resilience is very important. Remember, we have to cancel our PLT yesterday because the infection rate, we wanted to be our staff healthy and well-being, so they should be ready for any kind of surges coming. So I just wanted to look after the staff. So also provide the vaccination they needed, provide the PPE they needed, and make sure that they are ready when the crunch comes, so we can have enough staff. Also, make sure the body practices are also helping you. So that's only I have to tell, that don't become too much complacent. It hasn't gone yet. It will hit us, but be prepared. Thank you.
Thanks, Subir.
Did you want me just up, Anna, just to say, and this will be in the this will be in the information. If we just roll on to the next slide, Maggie, that we'll send out. Just to say that in addition to the COVID and flu vaccines, the roving team are offering a range of boosters and supports for young children, and then also there's a range of other services to support practices. So I won't go through it all, but the details are on that slide. And if practices want any assistance in terms of reaching some of those other groups, then reach out to the roving team, and we'll be happy to work with you to try and make sure that we can support around your own provision. Thank you.
Great. Thanks, Karen. And thanks for sharing that, because I think the roving team there is to support the practices. So please do make use of the team. There's an email that's gone out inviting practices to send their list. But if you've not received that, just send your list to the email address that was in the previous slide. So we've got Fabio from the primary care team, who's going to give us an update.
Hi, sorry, Fabio. My name is Waqqas. Hi, everyone. I'm the head of primary care. Initially, Fabio was going to give an update on COVID and flu, but I think Wax has covered most of it. I'll just give. Yeah, so what I'm going to do is I'm just going to give you a couple of updates around access. So in terms of, thank you. So in terms of access, so the direction of travel for PCNs are to deliver integrated access model, and this has been recommended as part of the Fuller report. The access and capacity plans can give an opportunities for PCNs to develop this infrastructure. So we recognize that the current model for the same-day access provides a seamless interface. And based on the feedback, it will not be possible to replicate this by 1st of October as part of the NEL-wide specification that was sent out and part of the engagement. Generally, from the feedback that we've shared with the specification, PCN CDs have kind of informed us they're not ready yet, certainly by 1st of October. And further engagement will be needed. And the CD is kind of also mentioned around some of the engagement around the 24/7 access offer and the focus on that. So what we are requesting is that the current service continues for another 6 months, which will take us to end of March, which will give PCNs the opportunity to work on the 24/7 primary care model for access. So what we'd want is we'd like PCN CDs to work with us and the current providers to develop a new service model. And if there are any PCNs that who feel that they could pilot the new model, we would be interested in working with you and NHC and the providers as a whole. So what we're trying to do is next steps. We're trying to pull together using various data and draft a model which we can then do engagement with the CDs and develop and help us steer us in terms of what works well and so on. And so we'll be hoping to do that in the next few weeks, and would love for you to be involved and really help us steer us and own it for going forward for Newham. If there's any questions or anything like that, I'll happily take any and try and answer them.
I think also just to add into that, just obviously around the 24/7 pathway is actually looking at obviously at out of hours, because obviously that is a key kind of requirement coming into the new financial year. So it's kind of wrapping up the same day access, as everybody calls it, if that's what we want to call it. I'm not sure we do, but actually it's that kind of, you know, access point of view of getting PCNs around their EA kind of element, but also the top up as you want to do it, that obviously is currently run by NHC, but also that kind of out of hours provision, so we can kind of wash it all together. And then obviously 111 will eventually come online as well, with a potential ask of maybe what can be done at a borough level rather than a NEL level. That contract has been extended until 2025. But obviously by working through the local models, that'll inform any procurement going forward of what that might look like. So thanks, Waqqas. I just thought I'd just add that in.
Right, thank you both. Does anybody have any questions? Nope. Okay. Oh, Fabio, I was actually going to ask, is there anything else that you wanted to add?
I don't have any question, but if I can pop in, because there have been some queries about the flu SLAs. Another email was sent on Wednesday. I just want to clarify that SLA to sign were the same that had the deadline to be signed by the 18th of August. Moira has asked NHS England to reopen them, and it's very important because there have been queries. It's very important that you sign those, at least the one relevant to you. And I'm talking about housebound patients and care homes. If you are not able to deliver flu vaccination to your eligible patients that are in those cohorts. And the other thing, I just wanted to remind everyone that NHS England and NEL ICB are running some webinar about long COVID. Information has been sent. It's worth for everyone to have a look at it. I can quickly put the link here in the chat. You can see here. Please don't overlook that, because it's a serious condition. Thank you very much.
Thank you. you, Fabio. And then can we also add the information with regards to that training into the newsletter? Because I think that will be very useful for us.
It was sent to in the bulletin, not last bulletin, the one before.
Okay, we'll also add it to the NHC newsletter as well.
Sorry,
Great,
this is an action for Karen. Yeah, okay, great, perfect.
Yep, thank you. Any more questions? No? Okay, thank you, everybody. So Ravneet is going to be talking about Health and Coaching Awareness Week.
Hi everyone, my name is Ravneet. Panesar, I'm a health and wellbeing coach. As part of Health and Wellbeing Awareness Week, they wanted me to come in and just update you on what we're up to. So I think it's still a little bit unfamiliar what we do. Please ask any questions in the chat and I'll address them as the meeting progresses. But we do support people with weight management, but we also cover a number of other things such as loneliness, managing, reversing long-term conditions such as diabetes type 2, cholesterol and high blood pressure. We also support people that suffer with anxiety and depression, low confidence and people needing motivation. Next slide. Health and wellbeing coaches are one of the 3 personalized care roles we work together. You may be familiar with social prescribers who have been in employment longer than health and wellbeing coaches in some instances. So we have a workforce development framework that initiates or guides us on the way that we should be practicing, and that's available on the NHS websites. But overall, this is a collaboration with us and patients towards self-management, and it's all part of the bigger picture of shared decision-making. And because we're not a clinical role, we are hopefully taking away non-clinical use of GP time. So this is why it's a really big benefit to you. We are exempt, however, from working with people with severe mental health issues, dementia or capacity issues. Next slide. I wanted to share one of my case studies since starting at Greengate Medical Practice. So I had a patient who came in to see me who was very unlikely to ever access health and wellbeing coaching in a private space or elsewhere, and was unsure actually what it was, but in that initial meeting, it's our role to connect with the individual. So referrals are made most often by healthcare assistants, some GPs who are now using the Joy app. And if you're not familiar, I'm actually really happy to take emails around the Joy app. It's proving to be really valuable, especially as we are now moving into working in multiple practices. So I'm in Project Street today and I've been able to pick up patients from the Joy app. So the doctors can do this directly with Joy, or we should be connecting with everyone in our practices so that you know the best way to communicate with us. And we want to make it as easy for you so that we can do the administrative side. You can write down an EMIS number. We are also supporting practice managers with specific targets. So for example, my lady I'm going to talk about had high blood pressure and a high BMI, but within that scope that I just shared. So my individual came with high blood pressure, a BMI, through a healthcare assistant. She just met with them. I was available. She came in to speak with me. You'll all be familiar in how anxious and worried the patient can feel at the time of a new diagnosis, and the panic around weight and wanting an immediate solution. She also said that at home, she was generally suffering from being quite snappy and short with her family and not being able to relax. And there was no time for exercise. So these were the key things that she presented with. Next slide. So what we typically do in that session is tailored around the individual. It's all around having them lead the conversation, and we invite them if we want to share advice, but we are, again, not prescriptive in our role. So in that safe space with me to explore her emotional and medical stresses, we were able to brainstorm activities that felt realistic for this individual. And this is also a tool in diverting them away from the overthinking and channeling their energy into more productive tasks that serve them. And this is very unique to the individual. As she understood her triggers and disruptors to her well-being, she was had a number of epiphany moments. And we were able to then look at the reflective use of the diversions and distractions in supporting her well-being. So we're reinforcing that positive self-led behavior. And next slide, you'll be pleased to know it's my last one. I'm very concise. As an outcome, over the course of 8 weeks, because even though we do up to 5 sessions, life happens, and it's about being understanding to the circumstance. There was a bereavement and, work challenges and summer holiday challenges. However, because of the way in which the patient was empowered, she continued the practices in the absence of our sessions. So we were able to stagger them towards the end part. She lowered her BP, she's decreased her BMI, and I love to suggest people use the Active 10 app, which is an NHS promoted app, sister to the Couch 25K one. It allows them to take a step back and reflect. But she also then was able to use these self-empowered behaviors to do other things that people may not assume are directly associated to her health. But that is looking for a job. So as you can imagine, this is somebody that was presenting with like a lot of minor ailments, thumb pain, sleeping issues. But we've seen now her number of appointments with the GP reduce because there's a self-activation within her. And then my last slide, I lied to you, sorry, accidentally. I just wanted to say that within Newham specifically, I find that we're serving communities that may be unlikely to engage and in practices that may not have come more naturally to them, or they may not have picked up, because what we can find in a highly South Asian community is that they really much want prescriptive, tell me what to do and give me the medicine. It's a safe place to share. So often they may be going to appointments with others in the family, but they can come alone because their partners, or they may not be assuming that there's some sort of like medical diagnosis that they want to be intervening on. They see it as a more soft subject, so they kind of leave individuals to it. And that's a generic, generalized opinion from my experience. We're building trust and accountability with our population, and obviously we want to be supporting towards health equity across the board. I do want to flag, it's not all it's not all wonderful news. We are seeing a lot of people that are just generally coming through with housing issues. So we then work with that triage approach and refer them to our social prescriber. And it is, and some people might be like, oh, it's a little bit like counselling. We are creating a space for them to offload. So we're seeing a lot of that kind of lower level mental health intervention around the anxiety and depression. Would you like me to just answer the questions in the chat? Is that okay? Yeah.
Yes, please.
Thank you. Thank you for your time.
Thanks, Ravneet. So there's a few comments and questions. If you're happy, do you want me to read them out to you, or?
I'm happy to respond to individuals in the chat if that's okay with them.
Yeah, that's fine.
Yeah,
that's good. All right, thanks, Ravneet, for that. Imrana, I can't see you. Is Imrana on? Yes, hi, Imrana. So Imrana's our clinical lead for mental health, who's going to be giving us an update today. Thanks, Imrana.
Thanks, Arpana. Thank you so much. I'm so delighted that we're running to time. I think it was 1:20, so I'm so happy. I might have a couple of extra minutes, but do stop me if you need to, because as you know, I can speak all day about mental health. So I'll just kind of go straight into it, and then perhaps we might have a couple of minutes at the end for questions and discussion. So I've got a lot of things on that list. But don't worry, a lot of these things, hopefully most of these things you know about through kind of various means, and a lot of it is on the kind of the flow diagram the updated flow diagram that I had, that's well circulated. So don't be alarmed by the amount of things on there, but there are some kind of useful things for you guys, for everyone to note. So I'll just go through them one by one, but I'll go fairly quickly, and then hopefully it all makes sense. So if we go to the next slide, please. So a couple of things with children's mental health which have been updated. So they have worked with patient reps and just updated their referral form. So I would say it's more tweaked than changed, so it won't look very different, but hopefully what it will do will give us a kind of a smoother patient journey, because there's a consent for work with for the referrals to be sent to the voluntary sector partners that CAMS work with. So hopefully it won't be very different when you're filling it in. And while there's a crossover period, you absolutely should not have any referrals rejected because it's the wrong form. So it is, I am going to kind of just link up with CEG to have it put into Resource Publisher. And so there is a letter by the clinical director at CAMS, which is soon to be circulated through, primary care at ICB. But again, I had a quick question about that, because it seems like some of the updates, on which I'll get onto, about eating disorders were circulated through that means. But I think, I'm not sure, I don't know who to pick this up with, maybe Layla, that it looks like that's not a very complete list. It seems like from the response I've had for GP. So yeah, I think just again to hold, perhaps there's the link there, but I also put the referral form with the pack to be sent out with this. The other, I guess, the main thing which I wanted to highlight is there's this, I guess, pretty exciting. I don't know if you've heard about Luminova yet. So basically, it is a game that children can play, which is kind of one of the first approved, NICE recommended rather, digital therapies for children. And it's for mild to moderate difficulties, and it's a self-referral. So, I mean, if you think about if a child had come in with their parent with anxiety in this age group, we would literally have nothing to offer them. So this is something that can be offered, and it doesn't require kind of back office work from a clinician, and it's regulated and NICE recommended, and also, sorry, it's free. So it's NHS funded. ELFT and this company have worked together to develop it, and so for Newham patients it's free. So there's a link for how to access it, but basically the front page of Newham website, the Newham CAMS website, it's very obvious from there. So at the moment it's kind of being rolled out through schools. So when children have difficulty at schools, it's the mental health teams within the schools are signposting, referring to them, but there's no reason absolutely why GPs can't do so. So I've got it, and then also just, I'm sure everyone knows, there is COOth still around, so that's for general counselling, anonymous counselling for all teenagers, and that's a wider offer, and that continues. This is just something that there wasn't anything for this specific cohort. So next slide will just give you a picture, I think, of what Luminova looks like. So that's if you Google CAMS Newham, you'll get to the website, and it's quite obvious, and you can click through there. You don't need to do anything, the parent does everything. So that's I thought was quite exciting. So the next thing, again, this is quite chunky, but I will try and keep it very succinct. GPs have been having issues with the crisis line, and just to, I guess, reassure people that a lot of those concerns have been heard, and there are kind of actions that have followed from that. So there's been a letter literally just sent back to LMC to kind of go through some of these things. And then we'll hopefully have maybe another kind of forum, maybe at the transformation meeting, to chat about this in more detail if needed. But basically, if you're having issues getting with the response you get from crisis line, Dominic, who's the clinical director for psychiatry, and Ed, who leads all the crisis work within ELFT, they are very happy for you to contact them, and they will get back to you ASAP. The other thing is, so if sometimes GP is saying we're struggling to get through on the line, although again, all the data they send us back regarding the time to pick up does seem quite short, but if you're having issues getting through, what they have said is that you can literally give your patient a letter or no letter, and ask them just to walk up to the crisis assessment unit at Newham Hospital, and then they will see them. And also, they're kind of working through regular ways of trying to kind of connect and get feedback from us. I think recently, unfortunately, one of our regs I can't remember which practice in Newham was struggling with a crisis patient. So, I linked him up with Ed, and they're just they kind of already arranged a kind of a chat to how to kind of improve that. As well as that, we don't want to have to always feed back. We want the system to work for us and our patients. So there is a QI project going on about kind of improving the system. But again, we wanted some quick wins. So we felt this would be some things that would be useful, that we can see hopefully the difference from now.
Imrana, sorry, I'm just going to interrupt because there's a comment from Laura, and it's with regards to what you're discussing now. So if you've got a crisis, if you've got a patient that's in crisis that's with you, what's the number that we call? It's the same number as the one the patients are calling, because Laura's asking for some feedback in terms of where I think she's had a meeting where she asked for there to be a separate GP line number. And the feedback that she was given was that you had said that this would create confusion. So I don't know if you want to just pick that point up now.
Fab, yes, I wasn't sure how much detail to go into, so I am aware of that discussion. So I don't know if you remember, initially they were, when the crisis line was developed, and until literally a few months ago, there were two numbers. There was a crisis line, which is that free phone number anyone can call, including GPs, and there was a dedicated GP line. And so what that line was basically like the bypass line for the crisis hub. So that line would go through to the administrator at the hub, and then they would put the GP, they would find the senior clinician and kind of link you up straight away. So that was hopefully bypassing the the standard number. But what we found is a few things. One is that because that's just a bypass line being picked up by the administrator, they were, just that scenario that one administrator's gone to the, having a break, then getting some tea and coming back, and then there were issues with access. And because that was just the admin line, they don't have that kind of quality assurance and data that they were giving us about the crisis line itself. And then again, honestly, I was having so much feedback from different GPs about being confused about which number to call. And although it was only two numbers and it looked straightforward, we made the decision that actually let's just have that one number. And the other thing to just bear in mind is that if a patient is in crisis, you don't want them waiting long either. So I think having one line and it's picked up quickly by whoever calls that line just felt like that was the kind of the best way to go forward. But again, the mental health team are not averse to having a GP line if we want to try that again and see how if we want to go through that route. So happy to have a discussion offline and then just kind of come to a decision regarding that. So that is something live that we're working through. That's quite a long. I'm not perfect. I'm multitasking. So Laura, I will read that perhaps at the end. The rest of it at the end.
Imrana, you've covered it, but I think it might be worth looking at to see what other feedback, maybe gather feedback from other GPs to see what their thoughts are on having a separate GP number.
Perfect, thanks. So Laura, do you want to come in now?
Yeah, just I mean, I'm surprised if there's been a lot of confusion, because surely it should just be an email sent out. This is the one for GPs, this is the one for patients. And I accept, in terms of admin might be off making a cup of tea or something, but hopefully that would be something that could be developed, just like we have admin teams, we have reception teams. If someone goes off to get a cup of tea, someone else is covering. It's a very important pathway in, and we've usually got a patient in crisis, we're in the middle of clinic, and I don't feel like the waiting times and for us to be waiting with the patient is appropriate. I have noticed that the waiting times have improved a little bit, which is great, but I don't know of any other speciality where we just have to wait on the line, the same as what the patients do when they're in crisis. We're making a referral, and so I don't fully understand. Personally, I don't feel like the reasons to not have it are as strong as the reasons to have it, but I don't know if other people agree or disagree.
Yeah, I think it sounds like we just need to have have that conversation again, perhaps, and then come to a decision. But there was a lot of confusion. I know it sounds very simple. How can there be confusion? But there was a lot of confusion about which line, when, why are people not picking up? So yeah, absolutely, it's not off the cards at all, off the table. And if we think as a collective that's going to be helpful, we can again develop that. The only just caveat for that is that. As most people know, particularly those who are working in urgent care, there's that big change coming in April with 111, and they're going to have the direct bypass to crisis lines, so there's going to be a big change there as well. So some of the argument is that hold off, this it's all going to change in April. My argument is actually that's not good enough. We need the change now, and then as things change, we need to evolve and develop. Fab. So I will move on, and then if you've got time at the end, we can talk about it further. So again, hopefully, again, I just wanted a quick hand of people who've received this email, so that they just a reminder that eating disorders in adults, if you remember I guess not the good old days, a few years ago, we'd only refer to St Anne's and they would never accept anyone because nobody was at that threshold. And then patients hated going all the way to Haringey or Barnet, where it is. And so now we do have a pathway. So if it's mild, or you can send it to Newham Talking Therapies. Severe and still goes to St Anne's, and then there's the local service within East London, which is a self-referral. Hopefully the beauty of it is it should be seamless for the patient. So wherever they go, they will get to the right part of the service. And also there's a kind of a cheat sheet that has been developed for which is I think on the next slide, just to remind us roughly what kind of patients would go for, would be suitable, which of these services. So this was sent as a mail shot to all GPs in primary care through the ICB pathway on the 31st of July, but I didn't receive it, and actually I've heard other people haven't as well, so I don't know if that's something we need to pick up on as the best ways of circulating the information. And also they came in the PLT, so that was done on mental health. Hopefully none of this is new information for you. Fab. Next slide, please. Yeah, that was just the cheat sheet, which is I think quite useful. You should have already seen it, and obviously it'll go out with this pack as well. They've also said that they're very happy to send posters and leaflets for practices if people want. Yeah, so I think that was on the email anyway, but reach out if you'd like any of that. So again, Kim's update. Again, there's so much to talk about, but again, we have had concerns, and very real concerns, about some of the care that patients have had in Kim's. So there are quite a lot of things changing, and so that those concerns have been seen and heard, which is positive. The change is happening. So you will see there will be a change in staff. A lot of the staff will be changing. There is some restructuring going on. I mean, one of the positives is that the waiting times are coming down. Just a flag that we used to have this very, very useful, helpful mental health pharmacist. I think he interacted with so many of us. Show was his name, but he had left, and there was a little gap, and I think people had forgotten actually there is this service that of using the mental health pharmacist for advice. So we do have 2 of them now within Newham, and it's the same email that's in the circulated list of key contacts in mental health. And particularly with your clinical pharmacists, just remind them that this is a really useful resource to reach out to with medications. EPCS, which we all loved, I think a lot of us have very fond memories about, unfortunately was paused, really was stopped when the KIMS was being developed, but that's starting rollout. The practices who are rolling that out should know who they are already, and if you're not on that list, then just reach out. And again, just a reminder, I think we're coming to the transformation group next week to talk about this in more detail, but the GP mental health leads per PCN, it's again a renewed commitment, and kind of the roles have been more defined, and then so that's a really kind of a useful offer that's still available. I think I've got, if you can just move on to the next slide. Again, this is just to show that it's more defined the role than initially when it was offered. So that may be helpful for people who are thinking about it, but hopefully we'll talk next week about that in more detail. And if we can have the next slide. Which was just general updates. These are things that you know, but just to remind you. So Keeping Well Nell, which is the hub for staff wellbeing. Again, probably you didn't know about this, but it was all happening in the background. That a lot of money was put into this during COVID. Then the money was pulled, but now they've got kind of a slimmed down version of what they offer, but they still offer quite a lot of useful things. So bear that in mind for yourself and your staff. Again, something that kind of doesn't get on our radar a lot is psychosexual health. So, All East, where we refer for kind of our coiled implants and family planning, they also offer psychosexual support. So, and that's again self-referral through All East. Just so we are aware of that. And again, another digital resource. All of this is already on that kind of pathway that that most people have seen. Is this digital resource for Londoners. It's called Good Thinking, and I've just put some pictures up there just to show you that it's really easy for patients to navigate, and in particular for kind of our cohort, they've got some culturally adapted resources in the faith and belief community section, and so in our practice we've just got an accurate text for Good Thinking because it's so useful and we use it quite often. So just a reminder to have a look at that, and it's free resources and apps on there. And I think that's it for me. So I was just going to remind you, so don't worry, I've run through a lot now, but most of those things are already on the pathway that most people have, hopefully all of you have seen and are using. And the things that aren't on there, so in version 3, which hopefully we'll put out soon, and the one that hopefully will go on to the ICB library, that's the NEL-wide library that's being developed, will have hopefully will have everything that I've said today on there. So that was kind of, I know, a very whistle-stop tour, and I think I've gone over time as well. Apologies, Arpana.
That's all right, Imrana. Thank you so much. Lots of useful information there, relevant to patients as well as all of us clinicians. Does anybody have any questions for Imrana? Nope. Okay, Imrana, there were a few comments from Dr. Sheetal Shah, and also the things that Laura Scott has mentioned as well. So if you could just look at that, I think that would be useful.
Fab, thanks. Thank you so much.
Okay, brilliant. So thanks to everybody for keeping on time. We're gonna we've got an open session now, so this is a really great opportunity to have a really good discussion with Dr. Rima. Rima, over to you.
Okay, thank you. Thank you so much, everyone. I hope you all had managed to have a break over the summer period. So as you know, there's lots of things that are going on, and I guess it can be quite challenging to kind of communicate this across. We used to have a very good face-to-face meeting practice council that used to be held at NUH, and I think that gave us an opportunity more to have an interactive session. And I feel like with these webinars, we don't really get an opportunity to actually hear from all of you. You know, what are the concerns? Are there any issues you want to raise? There are channels that are being currently sort of used, such as WhatsApp, where things are being put on and questions are being raised, but it's very difficult, especially for myself, to actually keep track of all of those things on that platform. I have spoken to colleagues at North East London and my representatives in the other boroughs, and we all use emails as a form of kind of raising issues, because then we can reply back, we can copy in the relevant leads in that area and have a trail of what the conversation is. So I just want to stress that, you know, if there are things on WhatsApp that I haven't responded to, it's not because I'm ignoring it, it's because I actually do not have the time to be going through WhatsApp messages. So please, I'm here as your borough director, clinical director, as your system lead to take on these issues. There's a lot of information that I hold that's helpful to kind of give back to you all. So please use these forums that we have in our governance structure at the moment to get some of that information back. So this is an opportunity really to ask questions. If there's any concerns, then please, you know, this is your opportunity. So fire away. And we're all here, we all have our expertise, and I'm sure it's not just me that we have to answer, but if there is anything else. Laura.
Hi, Rima. I think a lot of us aren't aware of all of the meetings that go on with all the commissioners and stuff like that.
Yeah.
Is there a way that we can almost get, I don't know, like a monthly bulletin of all of these issues that we've talked about for years and years and years, that we never really quite understand exactly what discussions have been had? So, for example, there might be some stuff that might be far down the line and there's work being done, and you know, it's either a hit and something's going to happen, or it's a miss because of X, Y, or Z. And sometimes that we keep on discussing the same things, but we don't. I personally don't feel like I get maybe enough information about what's being discussed at these high levels. And so, you know, for example, Unified Voice would potentially be a way of communicating that, and then maybe us bringing stuff to you taking it to commissioners, then feeding it back to us next time, but also as well, you know, having almost like minutes almost, like what's the update in this area, because otherwise it just really feels like we're going over the same things, and we sometimes feel, even though I don't think it's the case, not listened to because we don't know what's happening.
Yeah, I think that's really valid, Laura, and I guess that's probably why I wanted to kind of mention it today. So I guess there are a number of different forums, and we're in the process of going through what that governance structure looks for specifically for primary care. And I think we have so many meetings that it's difficult to, you know, condense everything into things that are relevant. You know, where do things go to, and how is it escalated up? Now, I unfortunately don't have the capacity to be able to attend all the meetings. I know that you have unified voice, that's on a Tuesday, that's on my on-call day, so it's impossible for me to attend. However, there are ways of me looking through the minutes and saying, okay, Rima, look, there's a point being raised in unified voice. Can you look into it? Is there a place that this can be actioned? Now, a lot of the information, so a lot of points that are raised, let's say on the WhatsApp, are actually things that are discussed at a North East London level, and there are outputs from it. But I'm more than happy to respond to those, and you know, that could be even brought up here, or it could be brought up through emails. I think we need to look at our communication process. So we've got some new communication leads within the borough partnership, which will specifically look into kind of how that information is disseminated. Now, obviously, primary care is only one branch of the entire system, so it's about how we sort of linking that all together and communicating things effectively to all the partners, not just primary care. And that's a huge challenge. Obviously, LMC, you have your LMC forum, which is also at a North East London level. So a lot of things that you've actually raised at a local level are being discussed already at a North East London level. And I don't know who the representations are within from Newham, if there are any on the NEL sort of LMC part, but it's kind of just making sure that we have those channels of communication. But I'm more than happy, if things are raised to me formally via email, I'm more than happy to respond. I know, Laura, we've had communications before with MSK and all of that, and I've always sort of tried my best to kind of involve people and respond back, and that's the method, and that needs to be formalized in that way, if that's okay. But I'm more than happy to look at the outputs of the unified voice and the actions, and if there's anything I can help with, I'm happy to feed that back.
Thank you.
Okay, so Waqqas has got his hand up.
Hi, Waqqas.
Yeah, hi, buddy. Yeah, so just following on from what Laura was saying. To be honest, there's been a massive cult in meetings. There isn't actually. So, I mean, the big one that we all go to, that we share stuff and it's available to everybody, is the Health and Wellbeing Board and the Transformation Group. And all CDs, LMC are all invited. We've got the Clinical Senate and we've got the forum here. That's from a primary care perspective. The Borough Partnership, I guess, is the one. But again, I'm sure those papers are shared, right, Rima?
Yeah.
I'll have a look through from, and then I guess we could ask Rima the Senate for other clinical leads to look through to see whether there's any papers and stuff that could be shared from other meetings, maybe. But to reassure colleagues that for stuff further down the line, we're very much PCN driven and sort of PCN CD led. There's good representation, and I'd like to think also that there's, you know, actually good representation from LMC on all of the forums as well. So certainly the ones that I'm attending, there's always a CD or an LMC representative there. So yeah, thank you.
Thanks, Waqqas.
Can I just make one comment? So I think what I'm taking away from what we're discussing here is that there needs to be a bit of clarity. So if you're a GP, you don't have any other role apart from your GP role. How do you know who to go to for what? How do you know what meeting you as a GP can attend? How do you know what meeting you could attend in your capacity as a manager? So, and if you want something to be raised at a different meeting, who is the person to go to? So yeah. I think, you know, the NHC website has got a breakdown of all of the PCNs and all of the clinical directors, but maybe we can look at doing something Karen, to say, you know, these are all the meetings, and
Yeah.
it's this meeting that this, like, for example, your CD will be attending this meeting. So if something needs to be raised, you as a GP or as a manager can go to your CD to raise the point on your behalf.
Yeah, I think that's really helpful. I think that's really important, and the first thing is to actually look at all the forums that we have first, and I know we need to kind of consolidate them down, and then once we've agreed that as a governance within primary care, we can then put that all on the NHC website for information. But as you said, at the moment, sort of that GP, sort of those questions are just being fired into on sort of the mobile phone and WhatsApp, and it's not really the right appropriate thing, because they're not going to get the answers that they need, and things will keep coming back, as Laura mentioned before. So you're right in terms of we just need to be clear which forums everyone is attending and where they get that information from. But obviously, I'm here if there's anything specifically that you feel you're not getting the answer from any of those forums in, please just contact me directly. You email me or you call me.
Thanks, Rima. Tammy?
So I think you kind of just completely summarised what I wanted to say. So that's really good. And I think it'd be really helpful, because I was sharing something with Shimi just about building that matrix of Newham meetings. And I think it's really important that we do have, you know, transparency, so we know where to take the decisions. But it's also that two-way communication. So if a decision has been made and we've agreed that as a system, it needs to be somewhere that we can all access. Now, whether that be you know, sort of a website that we're hosting, or whether it's going to be NHC that does that, I think that would be, you know, we just need to have that communication, because I think what's really important is that we still don't know where the minutes are going. You know, who are they being shared with? Are they being shared with the appropriate people? Is it something that we should, as the whole of the Newham GPs, have access to? So I think we need to have some discussions around that. But ideally, you know, it doesn't matter if you haven't got a clinical lead role, you're not a CD. As a GP in Newham, you should be able to access all of the information and then know where to go for help. And I think that will save a lot of the WhatsApp messaging that none of us can keep up with. Okay, none of us can keep up with, but we need an effective way to communicate our issues. So we just need to agree that, I think. But,
absolutely. And just to feedback on that point, Tammy, so North East London are looking at their web page. Okay, so looking at how they are disseminating information through their web page, we fed back and said, well, actually, we still need to have something local, because yes, there will be policies that are now, they're trying to shift to everything being across North East London, but within Newham, we'll have our own services and information that we need to put up. So it's about kind of what platforms do we use. We already have, obviously, NHC there already, so it's whether we expand and build on that, which is an existing way of communicating, but it's just making sure that all of those things are transparent, as you said, Tammy. So yeah, totally agree with you.
And the website that Rima was referring to, Joe's kindly just put the website link into the chat bar if people want to have a look. Karen?
Yeah, it was partly to address the points that have been raised, that I'd be very happy to work with colleagues to create that sort of matrix oversight and have it, if it's useful, on the website. I think from my experience, where I see the transformation group actually sees an awful lot of this information and is probably the strongest driver with the PCMs of how decisions get framed in a Newham context, if you like. So just as someone who attends the Borough Partnership and the Transformation Group and the CDs forums, the Transformation Group and the PCM forums seem to have the most granular conversations about how services are. And I acknowledge that obviously NEL sets some frameworks that then potentially impact the context of the Newham delivery. But it ways, you know, the Transformation Group and the sort of PCNs that end up actually making it work. That was just an observation from me. That's what I see happens. I appreciate sometimes the framework that NHS England sets or that NEL sets is quite hard to work within, but I guess those are the pieces that then get turned into what's appropriate for Newham.
Yeah. And I think it's about separating what the operational issues are and the strategic side. So obviously the borough partnership's there as a strategic body, if you want to call it that, and not really looking at the minute operational issues. But there are then themes that appear, and it's just then what forum are we using to address some of those operational things. And sometimes you've got the transformation, sometimes things just come to me, and I've got that secondary care interface through kind of catch-up meetings with Liat. So it's just about just kind of deciding where those things are taken.
Tammy?
Yeah, so just you asked us about a topic, didn't you? I think there's a lot of things that are happening in the system. So like the multidisciplinary diagnostic clinic, that's sort of just disappearing. In health, just disappearing. Like there are all of those things in the system that are happening elsewhere that our clinical leads don't even know about. They're picking it up on WhatsApp. It's where do we raise issues like that, so that it's not going, left, right, and centre. That there'll be some of those conversations that we need to be having. As GPs, unified in the fact that please do communicate or any of these changes. We cannot, as individual GPs, just be having referrals rejected, and then what do we do with patients? And we don't want all of us having to then go, oh, we need to know what the overall strategy is. So I agree with you, but that's something like that is big ticket stuff, and we need to know where those decisions are being made, who's making them, so that we can hold them to account. So that's something that quite rightly came up on the WhatsApp group, but where are we taking it?
Yeah, and so Tammy, I guess maybe then I'm not vocal enough that obviously I take that all on, and within us CDs, as in the borough CDs, we didn't even know about it, so we're finding out. We're then having conversations with the diagnostic team directly. In health, just to put that out, in health is not stopping. Okay, that was a rumour, and I've got clarity, and it's not actually stopping. So please continue to refer. They will accept referrals. When it comes to the other diagnostic centre, yes, that stopped. And that's caused an uproar, and they're looking into saying how they're kind of mitigating some of that risk. But that has been raised. I just haven't got an answer yet for it. But things are being pushed. I guess it's just making sure where do I, that you are all aware that I do a lot of these things and I have to feed it back. But it's just working out what forums are appropriate. And that's why I think something like this on the GP forum is just good to get some of those issues out. But again, if anybody to email, I'm more than happy to respond.
So Rima, just one other point with regards to what you're saying. So an example is the whole in-health thing and the MSK referrals. So one of the other things that I think will be useful to people that are working in Newham is who are the clinical leads. So if there is an issue for, I don't know, for example, with the TB service, and you're a practice that's having a problem with a particular pharmacist, who is it that you go to? It should be that we're going to the clinical lead. That's over. So I think we need some clarity on who the clinical leads are, because some of them are very upfront, very approachable, and then others, when you hear that, okay, this person is clinical lead for such and such area, you're like, oh, I never knew that, So I think that's another thing that we need some clarity with, and I think the clinical leads need to be more
visible.
Yeah. Thank you.
So on the NHC website is a whole list of all the clinical leads, what they lead in, and their email addresses. Everything's on there.
Yeah.
So, we all know that Imrana is our mental health lead because she is so visible, but there is a whole list of people on there. And if you don't get any response from them directly, then you come to me. But if there are particular leads that you're not getting anything from, you come to me.
I suppose the thing the reason what I'm trying to say is that I think that some of the clinical leads need to be more visible and more approachable, so that we as practices are able to contact them. So we're not putting things in a WhatsApp group that they may or may not even be on. They may or may not even read the message that they're able to help with.
Yeah. So why don't we do for the next session, or we'll look at the agenda items and we'll have every clinical lead attend that particular meeting and all introduce themselves, if that's helpful for everyone.
I think that would be, and also perhaps Subir, we can link it in with PLT. So say for example there's a cardiology meeting, it should be chaired, that meeting, the PLT should be chaired by the clinical lead in cardiology, and so forth.
sounds like a good idea. But we'll talk about that offline outside this meeting
sure.
to see what can be appropriate.
Laura?
Sorry, just really quickly. Another thing that came out of about the, the cancer Barts debacle that happened is then you get to learn the difference in what GPs can order in different areas. Why is it that City and Hackney GPs can order CT caps and we can't, and so on and so forth? And why aren't we all more aware of this stuff? Who is aware of it? Who makes these decisions? And it's all about this stuff about keeping stuff equal, but it's so obvious it is nowhere near equal when you look at the money that goes into other areas. And then, similar to what I was talking about in the WhatsApp about rheumatology, we're not even trusted with doing advice and referral to rheumatology. And I take the point that there's lots of positives to MSK, but it just goes down to you just feel like you don't have the same opportunities as in other areas, and we're supposed to be one area, one Nell, and we're not.
So on that rheumatology point, Laura, I was going to email yourself and Bipinda because I've looked at the figures and our referral rate rejection is not any more than any other area who are referring to Mile End or London.
But I would want to know why it was rejected though, and I'd want to have that clinician to clinician discussion rather than going through that filter process.
Yeah, so that's a very kind of small kind of micro thing that we need to then take up with specifically the rheumatology service. But that's being discussed in the advice and guidance through the planned care sort of discussions. I've asked to join that consortium for that one-off meeting to kind of raise that. But again, if you have that specific example, or it's helpful if I have the patient details and I can go back and say, can this be looked into directly?
Okay.
Because they say the overall figures is not that Newham referrals are being rejected more so than other areas. And if I look at all the specialities, actually rheumatology is probably fairly in the middle. There are some like hematology which are rejected more so. So again, I mean, these are all through kind of planned care. Our planned, unfortunately for us, we've got planned care clinical leads, but none of them are from Newham, and they're all from either Waltham Forest and Tower Hamlets. So I've identified that as a gap, and I've gone back to Julie Van Bussel, who's the manager lead for that area, to go back as to how do we mitigate that gap. But I've asked those clinical leads to come to one of these forums to at least introduce themselves. But yeah, just to respond back to that rheumatology, but I was going to email yourself and Bipinda separately about that.
Thank you.
And then your other thing about levelling up, Laura, Wax will know this from when he was chair back in the days. This has been there for years, and we constantly are fighting this battle. City and Hackney are not the model that the rest of the boroughs should be looking at how to replicate. They are set up completely differently, but we are all continuously fighting for that equity. Karen will know that, she's nodding, because in the borough partnership we have these conversations all the time. One big thing is around the financial resources and how we're even equalising that, because that's not even equal yet, and we've got other boroughs who are financially better off than we are in Newham. And Wax will know historically we continue to fight, but we have to continue that process. It's not going to be fixed overnight, but at least North East London are listening, and we are getting more resources through different ways into Newham slowly, which is really important. But to help with kind of the minute things, that has to be done at a more kind of local borough level, sorting it out, whereas you've got the overall arching Nell things that we continuously push on. And that's what the partnership's there to do, is to continuously press back to North East London, say the needs in Newham are greater. But yeah, just a feedback. Laura, is that okay? Was there anything else?
Yeah, no, that's great, thank you.
I do need to go. I'm so sorry.
I don't think there's any more hands up, Rima, but I think that was really useful. So thanks for having that small session. And I think that this is something that we can do as an ongoing thing if you're happy to, because I think it is actually very useful to all of us.
Yeah, no, absolutely happy to do that. And please communicate with me and email me if there's anything. All right.
Thanks, Rima. Okay. Does anybody have any other business that they wish to discuss? No, so okay, brilliant. Thanks everybody. Thanks everybody for keeping to time. We finished bang on time, so with a few minutes to spare. So thanks everybody. There's lots of information that's been shared in today's webinar, so that will all get circulated. And there's a few actions that Karen's nodding away that Karen's going to look at. So I think that that will be really useful to all of us. And Kavita, you've just added a comment about the unified voice meeting. So yes, I think that's on a Tuesday. So you know, clinicians, colleagues are welcome to attend that meeting as well. But I think once Karen and her comms team put together a sort of a matrix of the meetings, I think that will be useful for all of us to see what we are able to attend and share as well.
Just to confirm, we'll pull together the slides from today and the session references and the various referrals to information, and put that out in a note to you all early next.
Brilliant. Thanks everybody. Enjoy the rest of your afternoon and have a good weekend. Okay, bye.